Good morning. Thank you so much for having me present here again this year. And thank you to Dr. Jordan for starting us off by sharing Sebastian's story. And thank you to Ibne for joining us this year and sharing what our lab does at CDC and some of the exciting new work that you're doing in the lab at CDC. And I also want to thank Dr. Ali. They do fantastic work. They work quickly, and I know that hospitals and health departments appreciate that. So I like being able to say that we'll get results quick. All right. So I'll jump right in. I thought today that my role could be in trying to pull everything together. Where we sit at CDC, we have that unique perspective to be able to provide a national overview of PAM. And so I would like to talk about all the United States survivors today. If you were here last year, you got to hear Kaylee's story, and we got to hear Sebastian's this year. And so we're now at 4, which in most circles is not a big number. But when we're talking about PAM, 4 is a pretty exciting number, and it's a growing number. When I started this job in the summer of 2012, that number was 1, and it was a survivor that had occurred in 1978. And now I can stand here and say there's been 4, and 3 of those have occurred in the last 3 years. So that's pretty exciting. So in preparing for this, I went back, and I've looked at this case report a number of times, but I went back and looked at it again. So the infamous first survivor in the United States was a 9-year-old girl from California who had been swimming in the Deep Creek hot springs in the San Bernardino area of California. And her case, it was a very short publication, but it was published in the New England Journal of Medicine. And when I reviewed this case, I read this passage. The case report noted that the cells with amoeboid movement were observed by a technologist performing the spinal fluid cell count. And after hearing Sebastian's story, that I thought was important. That even back in 1978, there was a laboratory technician that was involved in the diagnosis. And some of you, when you were here last year, might have heard me talk about Dr. Vish Vishara, or Vish, who was instrumental in starting the Free Living Amoeba Laboratory at CDC. And he was involved with this case. And so I spoke with him recently to just talk with him again about this case and ask him what he remembered. And what he told me was that technologist had come to a parasitology course that was offered at CDC at the time, and she heard Dr. Vish give his talk about Naegleria. So when she went back and saw this case and was doing the cell count on the CSF, she was able to identify the amoeba and called Vish at CDC, and we were able to get specimens and grew. At that time, there was no PCR, but Vish was able to culture and grow the amoeba. And he said by the time he got an additional specimen, that the amoebas were disintegrating and there was no longer able to grow the amoeba. This case was treated with amphotericin B, both intravenously and intrathecally. She was given miconazole and rifampin. She stabilized within 48 hours and gradually improved over a month's time. And her amoebas were not found after 3 days of treatment. So as I've already mentioned, we waited 35 years until we got to have another survivor in the United States, and that was Kaylee Hardig, whose story was told here last year by Dr. Matt Lynham, the ID physician who treated her. Briefly, if you weren't here to hear her story, she was 12 years old at that time, and she enjoyed swimming at a small local water park. And after a few days after she had been to that water park, she developed a headache and fever. She was seen at Arkansas Children's Hospital within about 24 hours of her symptoms starting. And the interesting thing about Arkansas Children's is they had seen a previous case in 2010. And again, the laboratory technician that had seen that case and been involved in identifying the amoeba in that case in 2010 was there in 2013 when Kaylee came in. So again, we have another very astute laboratory technician involved. So we've heard about Kaylee. She was treated with the combination of drugs that included miltefosine, and her elevated intracranial pressure was aggressively treated with both neurosurgical interventions as well as therapeutic hypothermia, and that was the first time that technique was used in a PAM case. And she made a full recovery, and she's doing well as far as we know today. Just wanted to jump back once. I did pull these quotes from these papers and highlighted a few things. So this one from 1978, at the end they wrote, "The survival of our patient appeared to be related to early diagnosis, prompt intervention, and initiation of anti-amoebic therapy coupled with intensive supportive care." And compare that to what we wrote in Kaylee's case report. The patient's survival was likely the result of a variety of factors: early diagnosis and treatment, use of a combination of antimicrobial agents, and management of elevated intracranial pressure based on the principles of traumatic brain injury. A lot of people don't know that actually that same summer as Kaylee, there was a second survivor. His name is Abel, and he at that time was 8 years old, and he's from Texas. He survived, but sustained what is likely permanent brain injury from his infection. Interestingly, he came to the hospital, and Kaylee was actually still hospitalized at the time, and was making some headlines. And I believe her story even was making headlines on CNN. And he came to the University of Texas Health Science Center in San Antonio and was treated by Dr. Conrad, who is another ID physician who had treated a case a number of years earlier. And so he was familiar with PAM, and he had also seen some of the headlines around Kaylee. And so that's how he knew to call CDC. 2013 was the first summer we had miltefosine at CDC, and so that was making some headlines as well, and so as a result, he knew to call us. And so Abel was treated similarly to Kaylee. The hypothermia was not used in his case, but he was treated with the same drugs. We talk about why his outcome was not as good. And, a couple things we talk about is he presented several days into his illness. I think it was almost 5 days after he had become ill, while Kaylee came in very quickly. But it's hard to know why. But in his case report, we wrote that with increased awareness of this deadly infection, prompt diagnosis and initiation of combination drug therapy, and aggressive management of elevated intracranial pressure, more patients might survive PAM. And so that brings us up to this summer, and Sebastian's story has been already shared, and I know we're going to hear more, so I won't dwell on this too long, but I did want to point out another common theme. I listened with great interest to the press conference when Sebastian's case was announced, and heard about another story of an astute laboratory technician who recognized that she was looking at the CSF of a patient who was a young, otherwise young, healthy boy who she prompted or asked whether they had water exposure, and knew to look more closely at the CSF. And from what I understand, she attended this Amoeba Summit last year. And Sebastian also came to a hospital that has seen cases before. And so there was already an increased level of awareness here. So I wanted to just pull back now that we've reviewed those 4 survivors and identify some themes. I think it's hard to ignore, and the one I place at the top is early recognition and awareness among both clinicians and the laboratory. This is where I think the parent and advocacy organizations have played a huge role about spreading the word. I think it's in large part to your work in the last few years that the awareness has been raised. I I think in reviewing these survivors, I was really surprised to learn that there was an astute laboratory technician involved in 3 out of the 4 of these cases. And I placed this image here on this slide because this is what they're looking at. When you're doing a cell count on a CSF, this is a fixed and stained image of CSF, and you see all those white blood cells there. But right there in the middle, with the help of the arrow, you see Naegleria fowleri trophozoite. The second point is the aggressive management of the elevated intracranial pressure, which interestingly Sebastian did not have, but most others do. And this is what ultimately causes death in these patients. Our brains do not tolerate swelling, and so it needs to be aggressively managed as part of treating PAM. And then finally, Dr. Jordan provided a very nice overview of the drugs that are recommended. I'll point out the one theme among all 4 survivors, as well as the other international survivors that we have good documentation on. Amphotericin B is the common denominator used, or the common drug used in all of these cases. And yes, we know it's toxic, but amphotericin B is a drug that ID physicians are very familiar with, use a lot. It's our go-to big gun antifungal. And so the toxicities, we're familiar with it, and they can be managed. And so amphotericin B will continue to be used in the treatment of PAM. And then you see the others that Dr. Jordan reviewed. Miltefosine being the most recent addition, and we're really glad that this year we've seen improved availability now that it is commercially available. Just a few things. There are unknown factors that affect survival that we can't measure. They're what we call host factors, or things that are intrinsic to the patient, mainly their immune system and how they respond. This is seen in many types of infections and diseases. The same pathogen does not affect different people the same way. You see it when something, when everyone in a family comes down with the flu, one person skates by with minimal symptoms and another person has to take a day off and rest because they get so sick with it. And I think the same is true with PAM. Not every person responds the same way. And I think we saw that with Sebastian. He didn't have that elevated intracranial pressure. And maybe that was something to do with his immune system. And then there's the virulence factors that Dr. Ali's lab is really trying to get at. We don't think every Naegleria fowleri is the same. And so what makes them different, and what is it about the ones that infect patients that make them so deadly? So in the little bit of time I have left, I kind of turn to the numbers and statistics, which is what we do at CDC. We compile the case reports, we put the numbers out there so that we can all learn from them. And so here I have our figure that shows the number of cases per year going back to 1962. And I highlight here the last 5 years. We often get asked, are the number of cases increasing? And when you look at a figure like this, you see, they're not. We're not seeing a steep upward trend here. But what we do see is kind of, maybe stand this way, a filling in. As you can see, we haven't had a case or a year with 0 cases since 2004. And I think, again, this kind of has to do with awareness. Do I think there were 0 cases in 2004? Probably not. There was probably a case or 2 that might not have been recognized and went undiagnosed. So I think what we're seeing here with the filling in of our cases by year is increased awareness. And then I just want to review the changes that we've seen in the types of water involved in some of the more recent cases in the last 5 years. So first we have the cases that have occurred we traditionally think of this as being a southern state disease, and that might have been true in back in the early days of identifying this infection. But in the last 5 years, we've seen a northward expansion, and that really hit home in 2010 when the first case was identified in Minnesota. But since then, we've seen cases in Kansas and Indiana, and then this year we now have the case with confirmed exposure in Maryland. Oops. We had the cases in 2011, beginning in 2011, the 2 cases in Louisiana that were associated with using tap water in a neti pot. And then there was the additional case in 2013 in the child who was playing on the backyard slip and slide, again using water from the household tap. And it was with that investigation that we first identified Naegleria fowleri in a treated drinking water system in the United States. In 2012, we identified our first case in a patient who practiced ritual nasal rinsing. This is something that had been reported out of Pakistan previously, but we had not previously identified it in the United States. And this was in a 47-year-old male practicing Muslim who lived in St. Thomas. Last year, we saw a case out of California in water that was piped over land. This was in the Death Valley area of California, and it was at a private ranch where they had a pipe bringing water from a mountain spring in a pipe that traveled about 1.5 miles. That water coming out of the spring was around 50 degrees. By the time it reached the pool that it was being used to fill, it was 90 degrees, and it was being used to fill a pool that was not being maintained or treated with chlorine. And so that was the exposure in that case. We highlighted this one because it was reminiscent of cases that occurred in Australia in which their drinking water was being piped over land for hundreds of miles, and it was heating up and becoming an environment for Naegleria fowleri to thrive. And that brings us to this year. We are at 5 confirmed cases. The first one was another unique exposure. When we first heard about this case and were told that she had been whitewater rafting, we were a little perplexed. We don't typically think of whitewater as a risk factor. Whitewater rivers are typically cold rivers in the mountains with fast-moving water. However, when we learned a little bit more, we found out that the whitewater rafting had taken place at the U.S. National Whitewater Center in Charlotte, North Carolina, which is a completely closed-loop, artificial recirculated whitewater river. So at the request of North Carolina, we actually went up and investigated and did a site visit at this at the Whitewater Center. And unfortunately, I don't have time to probably share all that, but long story short, we found a lot of Naegleria fowleri in the water there. So in summary, as I think a lot of you already know, but exposures are no longer limited to southern states and purely recreational water. And so, again, highlights the need for awareness across the country. Finally, I just want to make a case for the continued role of public health in the study and involvement with PAM. There's been some changes where now that miltefosine's commercially available, you don't necessarily need to call CDC to get miltefosine. Testing's becoming a little bit more widely available. There are other places that have the PCR, so you don't necessarily need to call us for testing. But I would still argue that you should call us. We can provide a lot. We can investigate these exposures without CDC and state and local public health. These new exposures might not have been fully investigated, and we wouldn't know as much about them. I put these pictures here. These are pictures of one of our environmental microbiologists from our environmental microbiology lab up at the North Carolina Whitewater Center taking water samples. And these investigations allow us to document the changes that we're seeing in the last 5 years, the northward expansion, the new types of water exposures. And as I've said, we can provide the national perspective. When you call CDC and talk to one of us, we have the experience of having talked to all the clinicians that have treated these patients, and we can draw on their experiences. And we can if we don't know the answer, we can put you in touch with them. But I think a call to CDC is worthwhile when you're encountering a possible PAM case. And then finally, as you know, I showed you, we do the numbers. That's what we do, and we have our website, and we do spend a lot of time in making sure that that website is as comprehensive as possible. It is updated annually with the new case counts. And if you ever have suggestions for something that you think should be on our website, we're certainly open to that, and I'm happy to see that our fact sheet is being used. So finally, CDC is available 24/7 for both diagnostic and clinical assistance when you suspect an infection with free-living amoeba. You can talk to me or Dr. Ali about getting samples sent to CDC. We will try to make it as easy as possible. We know it can be complicated. And you can talk to us to get clinical guidance and support in treating these cases. All of that is available by calling our CDC Emergency Operations Center 24/7. So thank you.